Hi friends, this video will describe probably the safest technique of zero hydration, no rotation, in situ phaco chop in a patient with a suspected polar cataract. This patient had a suspicious looking posterior capsular plaque with multiple whorls and rings. I was not sure if it is a posterior subcapsular or polar cataract. However, I decided to treat it as a polar cataract. The capsular rhexis, I kept it slightly vertically oval because it is said that this vertically oval shape of capsular rhexis is ideally suited when you're dealing with a polar cataract, especially if you want to create an anterior optic capture or a posterior optic capture. So after turning off the retroglow, I am proceeding with phaco emulsification. Always switch off the retroglow when you're doing the phaco emulsification because this will give you a greater depth. Let us see the entire procedure in a totally unedited form. First, I'm decapping the epinucleus. Then burying the phaco tip into the grade 2 nucleosclerotic cataract, creating a through and through chop by initiating the chop close to the mid-periphery. Then with no rotation at all, I have not done any form of hydro procedure, neither hydrodissection nor hydrodelineation in this case. You have to just turn the phaco probe slightly to the left and right, then initiate the crack. And then once the crack is created, one of the nuclear fragments is evacuated from the eye. Sometimes because of the hydrodissection currents that issue out of the phaco probe, the nucleus will begin to rotate somewhere in the later stages of the procedure, but in this particular patient you'll see that I'm not going to attempt even the slightest form of nucleus rotation during phaco emulsification. The trick is not only to angle the phaco probe to the desired direction of the pieces, but also to turn the bevel in that direction. This will facilitate the vacuum working adequately and you will get an instant occlusion of the phaco tip. So not only turn the handpiece towards the phaco fragment, but also turn the bevel in that direction. This is the best way in which an occlusion can be achieved. Once you have got suitable occlusion, the piece can be mobilized and brought into the safe zone where you can apply short bursts of phaco emulsification. Remember that no cortical cleavage hydrodissection was done. The epinucleus removal in this case is going to be a little tricky and challenging, but you will find that when you use mechanical cleavage, this can be done quite easily. The vacuum here is about 300 millimeters of mercury. I am just using the Sinskey hook to create a kind of a mechanical separation between the epinucleus and the peripheral part of the capsule. After that, the vacuum takes over. So I've just turned on the retroglow at this point to enhance the view, and that's why there was a change in color. A combination of mechanical separation and the judicious use of vacuum only, no power is used at all, and almost all the cortex and epinucleus comes out in toto. The capsular bag is completely free and empty. Always beware the little piece that can be stuck to the side port. You have to do a side port toilet, get it out and aspirate it as well. The intraocular lens is a Hoyer 9X lens, and the way to implant this is once the leading haptic and the superior portion of the optic gets into the bag, you need to turn the bevel of the injector to about 180 degrees to release the trailing haptic, and then you have to tuck it into place. I'm going to show you also what is called securing the wound with zero stromal hydration. Just take a cotton bud and press it over the main incision, and this is generally enough to seal the main incision. All you have to do is inject very minuscule amounts of fluid or balanced salt solution through the side port incision, and this is usually enough to secure the incision sites. This is what I call the zero stromal hydration technique. Thank you for your attention.